I think metastatic disease, it's bone disease, it's an important topic because you're bound to deal with it a lot as an orthopaedic surgeon. It's not something you're going to be able to escape. Either whether you work in private or public, you're going to have to deal with it at some stage. And I think because due to the advances in our adjuvant therapies, people are living longer. They have a lot longer life expectancy, and we play a pretty important role in managing these patients, making sure we give them a reasonable quality of life. The last thing you want is a patient who you mismanage and they end up bedbound in pain for the next 6 months of the remainder of their lives. So it's very important to make sure you give them a good result that lasts the duration. And we now do a lot more. We're a lot more aggressive in managing these things. In the past, we nailed everything, plate everything, put them in slings, send them home, and send them to a palliative institution and give them lots of morphine, and that's the end of it. But there are a lot more we can do than we used to, with improvement in our surgical technique, improvement in our prosthesis, improvement in our internal fixation. So there are a lot more we can do to help these people. So the factors we need to consider is firstly diagnosis. It's very important we get diagnosis. We can't. It's not something you don't want to. You never want to go in operation not knowing, not being sure what you're dealing with. I saw a lady who had breast cancer 3 years ago, had all the treatments, and solitary lesion in the hip. And the oncologist's comment was, "I'm 95% sure that's a metastatic breast lesion." That's really, as an orthopaedic surgeon, that's not good enough for us. You go in there doing operation, doing Mickey Mouse operation, turns out to be a primary bone tumour, then you're screwed. So it's very important we get diagnosis. It could influence what you do. If that turns out to be a renal cell metastasis, you go open up. I don't know whether any of you have seen a renal cell bleed. I was lucky enough to see one, or unfortunate to see one, and I reckon I lost 1.5 litres of blood in 5 minutes. He just pissed out, and it's not something you can just put a finger on to stop. It just doesn't stop bleeding, and if it's in a position where you don't have tourniquet, it's really difficult, and your patient can literally die on the table. So you've got to know what you're dealing with. The type of tumour is very important because not only it determines the patient's life expectancy, it determines what you do, and we'll go through a bit more regarding that. Where there's solitary lesion, and solitary lesion we manage differently to someone who has multiple lesions. Locational lesion, a lesion in the femoral neck we treat very differently to one that's in the femoral shaft. And then you've got to consider the degree of pain, how disabled they are, what other symptoms they have, whether they have any neurological symptoms, especially in the spine. If they have neurological symptoms, then that may sway you to doing something for them rather than just giving them radiotherapy. Comorbidities and life expectancy. We do need to have some understanding of life expectancy of these patients. If we expect someone to have a prolonged life expectancy, then you have to treat them differently, you follow them differently to someone who will only have 6 months left. And we'll talk briefly about surgical options. So in terms of life expectancy, we spend a lot of time just speaking to medical oncology team, making sure they see the patient, document what they think, and we base our decisions on that. Most medical oncologists I've dealt with, they seem to be more optimistic than pessimistic. You may think someone with multiple lung mets may only live for 3 months, but they might think differently. And and there's a lot of advances in chemotherapy, and they have a lot of different trials, chemotherapy trials. So we can't keep up to that with all that. So it's hard for us to be sure exactly how long someone's lived. So it's almost impossible to predict how long they're going to live, unless obviously they look unwell, and you can say they're not going to. This palliative operation would be what you offer someone, but you always assume that they're going to live longer than what you think, because they do. I mean, how many of us have seen patients who've had metastatic breast CA and they come back 2-3 years later still? So in terms of prognostic factors, a lot of studies out there looking at what things you consider in order to determine their prognosis. And there's a few things which are important. Firstly, the type of tumour is very important. Some tumours grow more rapidly and more aggressive than others, and the ones typically have slow growth for breast, tumour, prostate. A lot of people with prostate tumours die from other things before they die from the prostate. Thyroid, multiple myeloma, lymphoma. The ones that tend to have poor prognosis, the rapid growth ones, such as lung cancer, gastric, and cellular carcinoma. If you have visceral or cerebral metastasis, then your prognosis becomes quite poor. And people with multiple skeletal metastasis, that's another poor prognostic factor. And there's a lot of studies out there quoting different numbers.